This is the Assembly Health Policy Committee, March 20, 2019. We're getting started a little bit late, but we are noticed from 12:30 to 1:30, and there's another meeting directly afterwards here. Let's go ahead and start by identifying ourselves to the record.
Austin Davidson.
Suzanne LaFrance.
Natasha Pineda.
Sarah Richardson. And in the back.
Deanna Fedko, Health Department. Linda Freeland, Anchorage Project Access.
And Mr. Gates is here. Thanks. Okay, so we'll go ahead and get started with the AHD update. And Melinda, is your presentation all ready to go for when we get to your
Yes,
item?
it's already loaded onto the laptop.
Okay, and I think we were hoping to give you about 30 minutes or so. So if we can.
We'll keep it. I'll keep it brief.
Okay. Thank you.
I'm just going to do a really brief department update. I wanted to let the committee know we have a policy recommendation almost complete related to the Anchorage, related to the Tobacco 21 ordinance, and so we should have that out to you soon. We were trying to get it done before last night, but it wasn't complete, so we will be sharing that. In addition, we did share that we oppose criminalizing the transmission of sexually transmitted infections and any proposed ordinances that seek to do so. We also provided that policy recommendation to the safety committee, and we'll continue to hold that position. And
Can I ask a question?
yeah.
Thank you, Madam Chair. Did you talk with Mr. Dyson about that? I know he's particularly interested in that issue.
Yeah, we provided it in January. I think we sent it in late January to him and Suzanne, and I think possibly the clerk and some other members. So if it's still not available, we can reissue it. I think Bill Falsey just resent it again. So we have provided that. It's about 2 pages. It's the same standard style of policy recommendation that we've been doing for the last couple of months.
Okay, thank you.
Yeah.
Sabrina.
Looks like you have a question.
Oh, Mr. Train?
Madam Chair, thank you. How soon will we have your policy recommendation on tobacco 21?
Hoping tomorrow.
Thank you, ma'am.
But yeah, there's an internal debate about whether we should add some other encourage other expansiveness to your ordinance, but it should be done tomorrow. We also wanted to thank you for the Public Health Week resolution. We will be sharing, I was going to go through all this, but I'm not because we're low on time, all the things we'll be doing during Public Health Week.
In this vein, if I could stop you for a moment, Mr. Gates has a question.
I'm sorry. Since we're talking about Tobacco 21 ordinance in about policy statement, there's another ordinance about prohibiting smoking within certain people that have non-positive labels for that point.
Yeah, we're going to make ours broad enough to just, in general, support tobacco, the different aspects of it. Tobacco 21 policy is a gold standard policy for cities that are looking to promote health. So we didn't specifically state your ordinance and the other ordinance, but made it broad enough that it includes, we're going to include public spaces and those other things as a part of our position. Mm-hmm.
And one moment, I believe we've been joined by Mr. Constant on the phone.
Yes.
Thank you.
So we do have a variety of activities planned for the public and for staff during Public Health Week. We will make that available to you. We have an Anchorage Wellness Warriors team that's participating in the APHA's 1 Billion Steps Challenge, and you're all invited to participate in that. I'll send you that after this meeting. This morning I challenged Chief Hettricks with the fire department and Sherry Hinshaw, the CEO of Volunteers of America, to our 30-day squat challenge. So we're starting to expand our internal wellness activities to other departments and local organizations. So I just thought that'd be fun to share. In terms of, there's a lot of different things happening within the department. I'll focus on what's coming up soon is something called Raging Contagion, which is happening April 10th to the 12th. It is a statewide exercise to prepare for a response to an infectious disease outbreak. So we will be participating in that. It's a multi-day activity. We'll be doing a large point of dispensing pod over at the Spenard Rec Center. So if you're interested in learning more about that or visiting or participating and seeing how that works, please let me know. And The other item of importance, let's see, there's a lot, but I'm just going to go straight down to the budget items. I wanted to update you guys. Last time we had an extensive discussion about the budget cuts. The HES subcommittee of House Finance met on 3/16, and they did not pass forward a variety of the cuts. So we are following that. They did not, the two that are particularly of interest to us are the cuts to public health nursing, the cuts to the human services matching grants. Those did not move forward, so they did not support those cuts. We'll be continuing to follow that as it makes it to the actual finance committee level, but at this point, those are held harmless, along with a variety of other things, so I'll include that in our report to you. The mayor sent a letter supporting the human services community matching grants, as well as many of the sub-recipients sent those through. So we'll continue to push forward on those items and keep you updated. And we will just go ahead and move straight into the substance abuse misuse presentation. Dang it.
Thank you, Ms. Pineda.
Yeah.
And you've been joined by Mr. Rivera.
Great. Okay, so we'll go ahead and go to the next slide. This is just a reminder of our values, visions, and our purpose. We can go to next slide. I'm the director of the health department. Sarah Richardson is here. She's our urban fellow. She'll introduce herself as she moves into her presentation portion. Elijah Gutierrez with the Alaska National Guard Counter Drug Support Program also helped with this presentation, but could not be here today. So as we have talked a little bit historically, we have been working on a substance misuse community assessment. The 2018 Providence Community Assessment identified these top 5 health needs in our community, and we have had the opportunity to have Sarah Richardson here with the Urban Fellow Program to do a deep dive into substance misuse. The main purpose of our focus has been to understand substance misuse, how it's affecting Anchorage, what the gaps in services are, and what are some high-level policy recommendations that we could work towards as a department and as a community. So the team went through quite an extensive process. The report is thick and lengthy. It includes a very extensive literature review, a collection of quantitative data, and then an extensive community qualitative data collection exercise that Sarah and Elijah conducted over the last few months. I know that some members have participated in those conversations as well as the community conversation, so thank you for that. The other thing I just wanted to kind of highlight and pinpoint as you start to see the actual report come out, we've based it on there's these 2 different processes by which prevention and substance misuse is categorized in both the mental health and behavioral health world and then public health. If I had more time, I would spend more time explaining this, but if you're interested, we can talk about that more in the future. But essentially, behavioral health and public health have 2 different but similar models by which they separate out the different types of interventions that a community would choose to put forward in any kind of community plan. So I'm going to hand it over to Sarah. She can introduce herself a little bit. She's going to give you a basic, brief overview into what we have found, and then talk a little bit about our next steps and some requests that we have from you.
Thank you. So I'm Sarah Richardson. I've been at the health department for about 6 months through a fellowship program. This assessment has been my primary work. I'm going to go into the really high-level top findings. There are a lot of smaller findings that we won't get into today. The first one, unsurprisingly, is that alcohol is a substance of most use and most misuse in Anchorage. What does that mean compared to all other substances? It contributes to the most deaths, the most ambulance transports, hospitalizations, OCS intakes, as well as other measures. Just have a couple graphs to kind of illustrate that. This is a graph of Anchorage area hospital discharges, outpatient and inpatient, in 2016 and 2017. You see outpatient discharges for alcohol-related reasons is up above 9,000 for both years, and inpatient down by 2,000. To give you a little context, there were 14 inpatient cannabis discharges and 53 psychostimulant, which is mostly methamphetamine. So that doesn't even really make it onto the graph compared to alcohol in terms of the effect on emergency rooms and hospitals. And then just another one, this is probably something you could predict, but alcohol use in Alaska among adults, about 56% of people report using alcohol at all in the past month. binge alcohol, which is misuse of alcohol, is at 26%. Marijuana and pain reliever use, misuse are the next most common, and then you see those harder drugs that we tend to talk about, cocaine, meth, and heroin at much lower levels than alcohol. So just another illustration of the way that alcohol is really, as the most accessible substance, one of also causing some of the biggest problems.
Got it. Mr. Trainee,
Thank you,
with a
Madam
question, and then Mr. Mason.
Because we've got an alcohol issue coming up with the ballot, is there any way we can get this information out to the public? Because I want the public to understand the
Yeah.
level of problem we've got related to alcohol in this state.
Yeah, and I do know that Recover Alaska does a good job of communicating out this, and they have been having that out. I'll make sure that you guys have access to this graph. The report itself isn't finalized and, for us to be able to release it, but it has quite a bit of alcohol-related data, and we're happy to share. These slides are public now. So.
Thank you, ma'am.
Thank you, Ms. Pineda. Thank you, Mr. Trainee. Ms. Quinn Davidson.
I was just wondering, and thank you, Suzanne, where you get these data?
Sure.
Because do people want to report if they've been using meth?
Yeah, great question. So the one on the left is from the Alaska Health Analytics and Vital Records, and we just requested the data.
Yeah, that makes sense, because that's
Right.
discharge.
Right,
So
right.
this one.
It's actually really common. The National Survey on Drug Use and Health is a federal survey done every year, and it's anonymous. And so there are a lot of surveys, the Youth Risk Behavior Survey, the Behavioral Risk Factor Survey, they all ask about drug use. It's all anonymous, and people tend to report fairly accurate data. And then this graph is from 2016-2017 population estimates. So they took the reported 2016 and 2017 adult rates and kind of did some calculations to make a more accurate population estimate. But yeah, people will report their use.
Thank you, Ms. Hutchinson. Ms. Quinn Davidson. Mr. Gates?
Yeah, wanted to understand the data as well. So now running together, the top column says used or misused or so it's alcohol use. That's just
Any alcohol
consumption
use at all, any alcohol use. And then misuse for alcohol is binge alcohol use, which is 4 or more drinks for males and 5 or more drinks for females in a row and like within a couple hours.
Wait, why is it more for females?
Sorry, opposite. 5 or more for males, 4 or more for females.
We're hardier.
I wasn't my girlfriend.
The second really important finding that we want to talk about today is polysubstance use, which means the misuse or use of 2 or more substances concurrently or at the same time. It is high in Anchorage, it's high nationally, it's not worse here than the United States. In particular though, opioid and stimulant, which usually means heroin and methamphetamine use together. I just have 2 graphs. The one on the tables, the one in blue is Alaska, and we're looking at drug overdose deaths from 2013 to 2017. There's a lot of numbers, but basically drug A and drug B are the 2 combinations of drugs that would result in overdose, and opioids and sedatives, which is primarily going to be benzodiazepines like Xanax and Valium, together contributed to 16.8% of overdoses, and then the second, opioids and psychostimulants, which is mostly methamphetamine, 11%. That's a pretty high rate, so that means people are dying with 2 drugs in their system. And then on the right, the orange one, I think that the Assembly has seen this data, but it's from 4A's, the Syringe Exchange Program. They've been tracking some demographic and data on people using the Syringe Exchange, and so we have data for 2,680 people. Yeah.
Can I ask a perhaps ignorant question, Madam Chair? Why would people only using meth use the needle exchange? I wasn't aware that you injected methamphetamine.
Yeah, that's like the
Definitely.
most effective way to use it.
You do, and as you progress through, any drug use, injection is kind of one of the most late stages in your drug use. So you might start with inhaling or eating, but then move to injection.
Something every day.
Yeah, and so you see that at the Syringe Exchange in Anchorage, 2,600 people, 21% are only using heroin, or report only using heroin, 20% only meth, and then the plurality, 38%, are using them combined. And we've spent a significant amount of time at 4A's for this assessment, speaking with people who are using drugs, and the primary reason that they've said that they're using heroin and meth together is just that the way that those drugs act in your body. Heroin is kind of a depressant, it'll slow you down, it slows your breathing. Meth will speed you up, and so to be able to feel those positive effects of heroin, you might want to take meth to keep you awake, for example.
So they would mix it and?
You can mix it or you can use them concurrently.
Do they call this a speedball too?
Well, speedball I believe is just for cocaine and heroin.
Do they have a term
And
for
it's from the
this?
90s.
So, there probably is a term for this.
I'm just kidding. Yeah.
Okay.
We didn't do that in our assessment, the modern
Yeah,
terms.
it's like one reason that polysubstance use is really important is that every time you continue to mix drugs, more and more drugs, the more dangerous that becomes for the person, and the higher the overdose risk, particularly if opioids are involved. And then preliminary 2018 data from Alaska and Anchorage indicates decreases in all drug overdose mortality citywide. So 2017 to 2018, there was a 41% decrease, again, this is preliminary numbers, in all drug overdose deaths, including a 51% decrease in all opioid overdoses, 50% in all prescription, 22% in heroin overdose deaths, 79 to 100% decrease in fentanyl overdose deaths. The reason that's a range is because Alaska Vital Statistics does not report when there are 5 or less deaths for data suppression reasons. So we know that there were 5 or less fentanyl-related deaths in 2018. So it was either 79% up to 100% decrease. And that 23% decrease in meth overdoses, and then just to kind of see the graph, you can see that 2017 was a really bad year in Anchorage for drug overdoses. 19 people died of fentanyl overdose in 2017. In 2018, it was back down below 5.
And we have a question from Mr. Trainee.
As a result of less deaths than just that Narcan or whatever it is that they're making available to everybody at the library too, as a way to bring them back when they're overdosed.
That's available for libraries. It's not, so it's available in a lot of places around the city, and that is one of the reasons that only works on opioids, and it will reverse an opioid overdose immediately, and it is highly effective, and that is probably one reason why we're seeing the drug overdose deaths drop, because it is mirroring the drop in opioid overdoses. There are other reasons. Again, we didn't see fentanyl deaths very high in 2018, and that could be because there is less fentanyl up here. It could also be because people using fentanyl have access to Narcan. It's really hard to tell, especially with fentanyl, because it can be it's often mixed into heroin, meth, cocaine, really anything. And people can know that they're using it, they can also not know that they're using it. So it's a tough thing to understand. But Narcan certainly has had an impact on the community.
One last question, Madam Chair. When you were going over the alcohol impact, did you guys look at the secondary impact on the babies that are being born, the mothers addicted to alcohol, and the societal cost? You're dealing with the children that now have FAS for the rest of their life. Did you guys look at that at all?
Yeah, so we looked at fetal alcohol spectrum disorders. We didn't look at the economic cost, but we do have numbers on populations most affected by that and discharge rates. It hasn't been necessarily increasing in terms of discharge rates and diagnoses of FASD, fetal alcohol spectrum disorder. In the last couple of years, it's pretty steady, which is also steady. Alcohol use is pretty steady. But the Alaska Native population is massively disproportionately overrepresented in terms of babies. I believe it's like 79% of discharges from Anchorage area hospitals for FASD are Alaska Native, and they're disproportionately represented in several other metrics, but that one I would say was the highest.
Thank you, Madam Chair.
Thank you. And there's, Mr. Nates?
Is that a statewide number?
Anchorage. This is all, for the most part, all Anchorage.
And the report itself is pretty dense and has a lot more detail than what we're providing to you now, but we'll be presenting how we would like to walk through the full report with you in the future.
Ms. Pineda, as we're running short on time, is this something then we could pick up next month? Or I understand Ms. Richardson's time is...
Yeah, we can, and so maybe we can skip forward to the kind of next steps, and you have the presentation in front of you. So we have some policy recommendations there's quite a few, and what we're actually going to be wanting to do with you guys and see who is interested in participating in this. We have Sarah is leaving us at the end of May. She's going to University of Michigan, plus the project is over, but we're going to miss Sarah. But she's also right now our resident expert, and we need to maximize that opportunity. And we would like to convene a policy work group in the month of April. We would be having 3 multi-hour meetings where we would stage those, where Sarah can actually walk the assembly members who are interested, plus some key community members over the whole entire report. It's an 1.5 inch thick binder. So there's some pre-work that would have to be done. We would convene an originating meeting. We would come back together and really decide on what policy recommendations the Assembly and the city could commit to for the next 24 months, and then finalize all of that in the third meeting. Then we would be able to publish the report and the policy recommendations for public comment while Sarah was still here to be able to answer questions, host community meetings, do more extensive presentations. In addition, during Public Health Week, Sarah will be doing some brown bag lunches about addiction and specifically opioids. So those are the things that we would like to do. So I don't know if we do that offline, and I just email you, our recommended dates, and how many of you are actually interested in participating in the policy review and selection process. And we did keep them, there's lots of things that can be done right at the community level. There's a lot of nonprofits that can do a lot of work, but we're really trying to focus on what can this Assembly and the department actually move forward that are policy level recommendations.
Thanks, I really like this idea. Any thoughts from members on how you want to proceed? Ms. Quinn Davidson?
Thanks, I think it's a great idea, and we can take advantage of Sarah's knowledge before she leaves. I'm wondering whether it's actually doable to do all that in April and have a public comment period and have, but I would.
We think it is, no.
That's great. I would love to be involved, others might too, but maybe you could follow up with us and then.
Yeah.
Mr. Dunbar?
Yeah, I really commend you for this as well. It's aggressive, but I hope we can do it. Just looking at your sample policy recommendations, I'm sorry we kind of skipped past that. I'm trying to visualize what it was that the study set out to do and what we're trying to do here. And when I do that, to me, the one at the top seems out of place to me. I'll just put it that way. This is a preview of the debate that I'm sure Mr. Trainee and I are going to have in 2 weeks.
On the night, sir.
That's right. We're talking about serious drugs, hard drugs, drugs you OD from, that kind of thing. And to me, that seems like something that I really do want us focusing on and drilling down. The cigarettes, the lesser extent of e-cigarettes, raising it to 21, I think it will feel different to the public. It'll seem like a different kind of thing to the public to do that, because cigarettes aren't the kind of thing you can OD from, right? Well, you can OD after you put a whole dip in your mouth, but
You just, die from it eventually.
usually just throw up. You don't usually die.
Only when you get cancer.
Yeah.
Yeah,
That
eventually
part,
you do,
yeah.
but so does using a cell phone, probably.
Of course.
So does being out in the sun too long. There are lots of
Yeah.
things that can cause cancer. It's not immediate like OD.
Well, this report is extensive, so these are samples. So there's how many are there?
At least 15.
There's about 15 actual policies. We just picked some random ones to put up here to say, there's a variety of different policy recommendations that came out of an extensive review of substance misuse in the city. And tobacco was covered. So it's not necessarily the headline policy recommendation. It's just a random sample of different policies that are in there. Some of these are things we wouldn't move forward or the policy group would not agree to. But we wanted to give you a sense of what's in there. The actual report kind of shows what's the evidence behind it, what kind of outcomes you could expect from such a policy recommendation. And so that's another reason why we want to go through an exercise of discussing them with the committee.
Can I just one follow-up question? And again, I apologize, I haven't seen the full thing. Other cities have moved to ban trans fats, for example, sugary drinks. Those are substances that are harmful. Obesity is now a leading cause of death in the country, or obesity-related complications, I should say. Is that part of this as well?
This was not focused on
So why did you
sugary
feel
drinks
that
and
tobacco
others.
is more dangerous than those other products?
Yeah.
I don't think that it's a prioritization of more dangerous or less dangerous. Tobacco is the second leading cause of preventable death in the United States, and so we do look at tobacco and marijuana and vaping in the report. And if you compare it, certainly heroin, meth, cocaine are harder substances in that sense and scarier, but the number of people using tobacco, marijuana, and alcohol are a lot higher. So policies that address the negative health impacts of those substances are going to have a broader reach on the community, certainly. And Tobacco 21 is, of all the, I know it's already kind of moving forward, but of all of our policies would have probably the most impact on the community as a whole, as opposed to addressing some that would be specifically for homeless individuals with injecting drug use, for example.
Thank you, Ms. Richardson, and we
better
do
go.
need to move on to the next presentation. Mr. Trady has the final
This is my
comment.
place, stick with me, on April 9th, we'll deal with the first one, begin to deal with it. This is a problem the military recognized a long time ago. We used to pass cigarettes out in your C ration. They stopped doing that. The military went to banning cigarette use in a lot of facilities because it was the long-term cost of medical coverage for military people. It's astronomical. So it's my hope this time we'll take this step on April 9th.
Thank you, Mr. Trady.
Thank you, guys.
And thank you,
Yeah,
Ms.
thanks.
Richardson, Ms. Pineda. It's very important data, and look forward to discussing it further. Welcome, Ms. Freeman.
Well, thank you.
So we are on agenda item C, Anchorage Project Access. Right?
Heard that by last night. Everybody had last night. Think you can still smoke. You want to purchase and smoke cigarettes on eBay.
Yes, but what they've done, and you know it, there's a lot of areas on it. So it used to be you were told you got an item, the military stopped doing that.
You can still have an 18-year-old soldier with a can of dip or a thing of cigarettes. You can still smoke when you're employed.
Yes, but you can't allow an 18-year-old to buy a handgun. Let's give him a gun and some will see, but we'll let him have one. Yeah.
Kind of let it slide in this
We'll talk
Don't
about
make
this
me
more,
use the
but-
gavel.
You're gonna allow 17 insurance.
Okay, there we go.
And then you'll just do your arrows.
Or should they do it all again?
Spacebar. Okay. Thank you. Good to see all of you again. My name is Melinda Freeman, and I am the Executive Director of Anchorage Project Access. And I appreciate the opportunity to talk with you about APA, as we call it, and to distinguish that we are not Access Alaska. So we'll start with that. And we are going to be talking today about how our program strengthens the safety net for healthcare in our community with compassion and efficiency. So Anchorage Project Access, our mission is to assist people who are low income or uninsured to access healthcare in their community by using a volunteer network of providers in a manner that is very organized and efficient and allows our donating providers to provide as much pro bono care as they choose to do. The reason that we were formed in the first place is from 1998. The community created the Access to Healthcare Coalition and decided that they would use a model that had been used in other states in the lower 48. As we know, we're often behind the times in some of social services in Alaska, and in this case, we are the only project access of its kind in the state of Alaska. And part of the reason is to reduce the overutilization of emergency departments for primary care. When you are homeless, when you are uninsured or underinsured, typically people use emergency departments for primary care, which is very expensive. There's uncompensated care. There's a continuity of care issue where individuals aren't receiving primary care to continue to help them prevent disease or deal with disease, as well as the cost to the community. If you are insured, we are bearing the cost of those that are uninsured. So a little bit about our history. With the Anchorage Access to Healthcare Coalition deciding on a program model based on a model out of Buncombe County, North Carolina, called Project Access. So in that process, they decided that they would issue a call to action from the community to request an agency to move this program forward, this idea of offering donated care from our local providers. And the entity that was selected that had the most experience with Christian Health Associates. Christian Health Associates is our umbrella organization under which we perform our job at Anchorage Project Access. CHA, as we call them, provides Cornerstone Medical Clinic, Cornerstone Counseling Clinic, Alaska Medical Missions, which provides donated medical equipment to developing countries. They also are responsible for opening the school-based health clinics, for those of you that are familiar with that, in addition to Healthy Smiles Forever, providing dental care and assisted living homes, and then Anchorage Project Access. So we are a DBA under Christian Health Associates, DBA under CHA, and any more acronyms you can think of. In addition to that, concurrently, we needed to have legislation that created the opportunity for providers to donate their care. If they did not have immunity from getting sued, then that would be a problem. Who would choose to donate their wonderful treatment and all the specialty treatment that they're donating through APA if they didn't have some protection? So other than gross negligence, HB 260 was passed into the Immunity for Providing Free Healthcare Services statute. So that protects them from being sued to some degree. In order to move this idea forward under Christian Health Associates, they created a physician leadership team, which are the founding members of APA, and they created the whole process for moving the effort forward. Our goals are to improve health outcomes for low-income uninsured individuals in our community. This is specifically for Anchorage, but up to 10% of the people we serve can be outside of the Anchorage goal. We serve people that live in Mat-Su Valley, Talkeetna, Willow, and we receive referrals through them. We also are oriented to increasing primary care treatment capacity in Anchorage through our efforts of connecting and referring back and forth. We want to increase the ability of doctors and dentists to donate their services, and we want to increase partnerships with other healthcare providers. So what do we do and how do we do it? First of all, to launch a program of this size in a community of 300,000 people, you need a minimum of 200 medical providers donating their care. Currently, we have 630 medical and dental providers donating their care through APA. The first order of business when we launched in 2005 was to create that cadre and cohort group of medical providers that were going to donate their services. So we're always recruiting providers. In fact, when all of us go to the dentist or doctor, we ask them if they're members of Anchorage Project Access. We also do extensive outreach to underserved populations. We provide outreach services on site at Brother Francis Shelter, at Beans Cafe, at the Alaska Mental Health Consumer Web. In addition to the new areas that we have, we provide outreach at Partners Reentry Center, at the Downtown Hope Center, at the Anchorage Health Department, Project Homeless Connect, and health fairs. We conduct extensive eligibility screening. A person who would like services and needs services through Anchorage Project Access has to meet up to 300% of federal poverty level and have a medical need. We enroll people into Anchorage Project Access. They actually have an APA medical card as well as a pharmacy card as we provide donated and discounted medication. We also coordinate all of their care. So an individual who's receiving donated care through APA, we schedule all of the specialty appointments as well as their transportation, interpreter services, and anything they might need. Community education is obvious, we're doing that here today, and all of the services that are provided by APA are free of charge. There's no fee involved. Yes?
Pause you one moment, Ms. Freeman. Mr. Dyson has joined the meeting. I believe Mr. Peterson is in the back as well.
Thank you. Feel free to ask questions. So Anchorage Project Access is part of meeting the social determinants of health. We're also a very active member in Healthy Alaskans 2020, soon to be Healthy Alaskans 2030. In addition to that, we have a great deal of representation across Anchorage as far as community impact and making sure that our healthcare system is responsive to the need. We sign up everyone that comes through our service if they are eligible for the Affordable Care Act Marketplace Insurance, Medicaid, public assistance, and we're about to begin Medicare enrollment as well. As again, we talked about providing interpreter services. A great deal of our population that we're serving is in need of interpreter services, and English is a second language. We create the access to donated care, as we've discussed, and we help patients and individuals navigate complex systems of care. Most of us have difficulty navigating complex systems of care, from co-pays to deductibles to premiums to out-of-pocket expenses. We'll have a referral for a person to be an APA patient and receive care, and they actually have insurance, they just didn't know how to use it. So we do not serve individuals who already have insurance, but we make sure that everyone we serve does sign up for insurance if they are eligible. This is some of the elements of our donated medical and dental care. As I said, we have over 630 medical and dental providers donating their care through APA. There is a need for, as we recognize in emergency departments, emergency dental services. Without strong oral health, it's hard to have overall health. So we added the dental program in 2016, and we have 50 dentists donating their care. We also do all ancillary care services that are also donated, from radiology to physical therapy to medication assistance, surgery centers. All of that is donated through APA if they are a provider. These are our funding partners. Half of our operating budget each year is from the state of Alaska, operating budget for DHSS. We also receive a very large donation every year from Providence Health and Services. In addition, we're funded from the municipality's mayor's grant, the Mental Health Trust Authority, United Way, fundraisers, and corporate donations. And our operating budget is about $535,000.
Ms. Freeman, do you
Yes.
know offhand the value of the donated services?
Yes, and we're going to hit that right now. We have served over 3,530 unique patients at APA who've been enrolled in receiving donated care. That results in over 8,500 treatments. So some of those people need more than 1 or 2 treatments, totaling up to 8,500 treatments. We've scheduled over 16,750 appointments for people since we've been open, and 100% of our APA patients, they participate in establishing a health home. Without a primary care home, it's hard to address some of the long-term problems that people are struggling with. We have patient evaluations pre and post treatment to determine their self-report on how they're doing from receiving the donated care. And of course, it's very positive how they're doing. We have facilitated over $47.7 million worth of donated care since we opened. We have a health insurance company that donates the in-kind donation of tracking all of the donated care. All of the physicians and dentists and radiologists and surgeons, they all submit their billing statement through Meritain Health System, and that is counted. They are not getting paid for the service, but they're processing it so we can keep track. So for every dollar that is contributed to the operating costs of Anchorage Project Access, generates $8 in donated care. So I wanted to tell you 2 brief patient stories. Both of these folks were willing to have their story told. On the left, you'll see Yvette. Yvette has worked all of her adult life, and she has never had insurance before encountering and interacting with Anchorage Project Access. When she came to us, she was referred by our primary referral source, which is Anchorage Neighborhood Health Center, as well as Providence Family Medicine Center. Those are the 2 primary referral sources into Anchorage Project Access. She was referred to us by ANHC for orthopedic care. While she was there, she asked if perhaps we had dental services that we can offer. She was a multiple victim, many times, of domestic violence. So she had a lot of missing teeth, she was in pain, as well as having very little confidence. So through our program, she received orthopedic care, all of that was donated. She received dental care, all of that was donated. And now you see she's very proud of her beautiful smile. And she has been working, and she has been clean and sober from her addictive problems for over 3 years. Then we have Alexander, who's on the right. He's a young man who is in the construction industry, and he was referred to us through Anchorage Neighborhood Health because of an abdominal problem in which he was diagnosed with a triple hernia, and he could not work in the construction field and lift 75 pounds if he did not have that treated. So Alexander received surgery through Anchorage Project Access and is working full-time, and very grateful for his care. And I think those were the most important stories to tell, because that's really why we exist. And again, we've helped thousands of people enroll in APA services, thousands of people enroll in health insurance now. So even with the expansion of Medicaid in 2015, and prior to that, the Affordable Care Act, we still have thousands of people in Alaska who do not have health insurance coverage, whether it's not affordable or they do not qualify for Medicaid. So it's very important that we continue to allow and facilitate our physicians and dentists to donate their care. Are there any questions about Anchorage Project Access?
Questions from members? Or Mr. Constant, are you still on the line?
I am, but I have no questions. Thank you.
Okay.
Thank you so much for letting me present.
Thank you, Ms. Freeman. I have a question. You mentioned that you line up interpreters and transportation. Are those also sometimes handled by volunteers? Like, do you have volunteer interpreters or volunteer drivers?
We do not have volunteer interpreters because interpreting is a very specific skill, and people need to be certified to do that, especially when you're talking about medical terminology. And so we use an interpreter service. We have this last time during open enrollment for ACA Marketplace Insurance, we did have a trained volunteer helping us with those applications. We do have people volunteering to transport, but it's usually family members. Any other questions?
Questions or comments from anybody? Thank you very much for
Thank
the
you.
information.
Thank you for the opportunity.
I appreciate it. That brings us to, well, unless there are any other questions or comments from
I had one,
Ms.
just Natasha,
Pineda?
one comment I forgot to say on behalf of some of the providers that were at the previous meeting. Just a reminder that the Emergency Cold Weather Shelter funding and contract ends April 30th, and then the homeless abatement camp process starts. And so if you look at those numbers and you have somewhere between 80 and 100 people using the Emergency Cold Weather Shelter, they will no longer be sheltered. And the health department does not have resources to continue that support for the emergency cold weather shelter services. So I just want to make sure I said that on behalf of the providers who are very concerned. We will be meeting some meetings to talk with them about communication when abatement happens, but the health department at this time has no more resources to give us. We have to save the resources we have for next fall when the cold weather starts again.
Thank you, Ms. Pineda. That brings us to audience participation. Is there anyone here who wishes to speak? No? Okay, any other final comments from members or anyone else? Okay, thank you all for being here. We are adjourned.